Good afternoon. I am presenting a case of a uterine arteriovenous malformation, which is a rare but a life-threatening condition. Certain key points are needed to be explained before I present this case. Uterine arteriovenous malformation is an abnormal communication between an artery and a vein. Patient would usually present with profuse or irregular vaginal bleeding, which is associated with postpartum and post-abortion. Etiology may be congenital or acquired. Ultrasound with color Doppler is the most common form of initial investigation. Traditionally, hysterectomy has been the treatment of choice for acute hemorrhage, and final diagnosis is usually done after a histopathology report. AVM is a rare condition. There are fewer than 100 cases reported worldwide. The first case of AVM was reported in 1926. In the Philippines, there's no reported case in the 10-year period by the Philippine Obstetrics and Gyncology Society, and this is the first case in United Doctors Medical Center. The following are my objectives. A 28-year-old, Gravida 1, Para 1, 1001, admitted due to profuse and prolonged vaginal bleeding. 3 years prior to consult, patient experienced profuse vaginal bleeding a week after her cesarean section, consuming 3 to 4 pads per day with pallor and body weakness. Patient was readmitted in a private hospital for delayed postpartum hemorrhage that was controlled without surgical intervention. 4 months after cesarean section, patient once again experienced profuse vaginal bleeding amounting to 2 to 3 diapers per day, fully soaked, now associated with loss of consciousness. Patient was in shock and had severe anemia. A transvaginal ultrasound showed anteverted average-sized uterus with homogeneous myometrium, thin menstrual-like endometrium, and normal ovaries. Initially, DNC was contemplated, but because of severe vaginal bleeding, laparotomy with bilateral hypogastric ligation was done. Intraoperative findings showed normal-sized uterus and annexate. However, after 15 to 20 minutes of ligation, bleeding was persistent, which prompted to do hysteroscopy to look for the definite site of the uterine bleeding. Hysteroscopy showed thin endometrium with active bleeding at the fundal and lower segment. A non-absorbable suture was noted above the internal cervical os. The rest was normal. Bleeding finally stopped after 30 minutes. Patient was transfused with blood and was discharged improved with minimal vaginal bleeding. Patient then resumed her normal menses. Until, after 3 years, patient was readmitted at UDMC due to prolonged and profuse vaginal bleeding. Upon her second admission, patient had stable vital signs. Uterine AVM was then suspected. Transvaginal ultrasound with color Doppler was done, which showed thin endometrium with rich color flow over the previous scar in lower uterine segment, seemingly extending to the myometrium, with rich color flow over mid-anterior wall extending to the anterior lining. Uterine AV malformation was then highly suspected. Treatment options were discussed with the patient. Uterine ablation was attempted at the start of the procedure, but due to severe bleeding, the procedure was aborted. Total abdominal hysterectomy was done, and operative findings showed average-sized uterus, smooth myometrium. Endometrium was noted to be thicker on the left anterior median, whereas on the contralateral side, the lining was barely noticeable, almost nude. Endometrial cavity was smooth. Histopathology report was consistent with arteriovenous malformation of the corpus uteri. The post-operative course was unremarkable. Patient was then discharged on the 4th hospital day improved. Congenital AVM abnormality is in the development of primitive vascular structures. The most common type, the acquired AVMs, usually develop after uterine trauma when there is the possibility of formation of abnormal communications between artery and veins during the healing process. An example are curettage and cesarean section as seen with our patient. Other etiologies for AVMs are the following. It is postulated that AVM may arise when venous sinuses become incorporated into the scars in the myometrium after necrosis of the chorionic villi. Acquired AVMs of the uterus are typically single, large connections between arteries and veins in comparison to congenital AVMs, which generally consist of multiple small vascular connections that may invade the surrounding structure and grow with the progress of pregnancy. Clinical features of AVMs may vary. Others may have intermittent bleeding. Some may have massive and sudden vaginal bleeding, which may be life-threatening, while some may present with secondary or late postpartum hemorrhage. But generally, it is refractory to usual methods of treatment. The following may be used for the diagnosis of AVMs: transvaginal sonography, ultrasound with color Doppler, angiography, and finally, histopathology. It was suggested that the true incidence of AVMs may be higher than reported, maybe because of low index of suspicion from clinicians as possible cause of intractable hemorrhage. Management of patients with symptomatic AVMs depends on hemodynamic stability, degree of bleeding, as well as age and desire for future pregnancy. The mainstay of acute treatment is to stabilize the hemodynamically unstable patient and to control the hemorrhage. Successful application of a Foley catheter with uterine packing and medical therapies has also been used to control acute blood loss. For stable patients, treatment options include expectant management, surgical removal of an AVM, laparoscopic bipolar coagulation of the uterine blood vessels, and long-term medical therapy with combined oral contraceptive pills are reported. In this case, bilateral hypogastric artery ligation was done, which believed to have controlled only the first episode of torrential bleeding. Angiographic uterine artery embolization may also be done. Currently, hysterectomy is only indicated for women who do not need fertility preservation, have limited access to medical facilities, and whom embolization therapy fails. Uterine AVM should be considered as a possibility in cases of refractory or intractable profuse vaginal bleeding. Though angiography is the gold standard diagnostic procedure, color Doppler sonography is an important and more practical tool for proper assessment of AVMs. Bilateral hypogastric ligation has been done with success, and there are evidences of success rates of using hypogastric artery ligation to control the bleeding of AV malformation. Hysterectomy should be option of last resort, and awareness and prompt decision-making is essential for optimal outcome. Thank you.